And so I'd like to welcome Sharon to the podium. She is a heart failure transplant cardiologist and clinician scientist at the University of Ottawa Heart Institute. She's also medical director of the Heart Transplant and Mechanical Circulatory Support Program, and also co-lead for the shock team at the Heart Institute. A bit of background. Dr. Chih attended medical school at the University of Western Australia in Perth. She undertook cardiology training at Sir Charles Gardner Hospital in Perth, and also followed by a PhD at the Victor Chang Cardiac Research Institute in Sydney. She did an advanced heart failure fellowship at the University of Toronto, and we were lucky enough to recruit her to the Heart Institute in 2014. Well, it seems like longer. She's also serves on the Scientific Review Committee for the Heart and Stroke Foundation of Canada and the Research Subcommittee for the Canadian Cardiac Transplant Network. Notable accomplishments include 2018 CCS Young Investigator Award. Woohoo! And she's also funded by the Heart and Stroke Foundation for many years. So looking forward to a great talk in cardiac allograft vasculopathy surveillance. Sharon, welcome.
Thanks, Daryl. Yep, to 2014. Does seem a bit longer than that. Okay, so this is my first time working this hybrid round, so hopefully I don't mess up the technology. So I've actually spoken a few times at these rounds on cardiac allograft vasculopathy. So today I would like to review imaging surveillance and also provide an update on some of the work that we've been doing related to this. So just to recap, screen is not obtruding, and it is not. So just to recap, differences between cardiac allograft vasculopathy and atherosclerotic coronary disease. So CAV is an accelerated fibroproliferative form of arteriosclerosis that occurs uniquely in the transplanted heart. And anatomically, it differs from traditional atherosclerotic disease in that it is a pan-arterial disease. It affects the entire length of the epicardial vessels and extends into the microvasculature. And pathologically, you see here on the right that it's characterized by concentric intimal hyperplasia that's due to vascular smooth muscle and endothelial cell proliferation, as well as this infiltrate by inflammatory cells, predominantly macrophages and lymphocytes. And that this results in this obliteration of the vessel lumen. And this is quite distinct to the eccentric focal plaque that you see on the left that we typically encounter in atherosclerotic coronary disease. In this case, we see a fibrotic plaque. Another very, very important difference is that CAV progresses much faster. Some series have noted an increase per year in the plaque atheroma volume of around about 3%. I'll show you data later in our series that this number is sort of closer to 5%, and this compares to 1% in the non-transplant population. CAV is important as a problem because it is a frequently encountered complication after transplant. And almost half of patients by 10 years post-transplant will have some degree of CAV. And to place this into context, this is relevant because the current median survival post-transplant is about 13 to 14 years. On the right, we see that CAV in the red here is a leading cause of graft failure and death post-transplant, and that beyond 1 year post-transplant, it accounts for 1 in 8 deaths. It also accounts for a large proportion of graft failure, which is shown here in the pink, which is also a leading cause of death post-transplant. In terms of surveillance, this is needed for several reasons. Firstly, the majority of patients will not experience any symptoms that you would typically encounter with myocardial ischemia because of graft innervation. And so surveillance is needed for early detection, and early detection is in turn important in order to implement changes in treatment, specifically with the mTOR inhibitors, mammalian targeted rapamycin inhibitors, or proliferation signal inhibitors. These are drugs such as sirolimus and everolimus, which are known to decrease both the rate of CAV progression as well as the incidence of CAV, but are not used routinely after transplant because of a considerable adverse side effect profile. These medications are also less effective if you use them later post-transplant in more established disease, where we also have more limited therapies. Surveillance in patients who have established CAV is also important because it can guide the need for invasive testing, as well as important management decisions such as revascularization or retransplant if there is graft dysfunction. Recommendations for management are centered around prevention. So we use statins immediately post-transplant. We prophylax all patients against cytomegalovirus, which is a common risk factor for development of CAV. And we also apply aggressive vascular risk factor management. As well, the current recommendations highlight or emphasize surveillance, which is usually undertaken with a combination of both invasive and non-invasive testing. But what is uncertain is what the best clinical practice with regards to surveillance should be. And that brings me to my objectives for today, which is firstly to discuss emergent technology for CAV evaluation, including intracoronary imaging with optical coherence tomography, OCT, invasive coronary flow, and PET assessment. And then secondly, to share with you the results of our recently completed ECAV study, which integrated the use of these modalities in examination of the early post-heart transplant population. And then to end briefly with future work in this area. A recent survey that we conducted on institutional practice on surveillance of CAV. And you see on the top panel that 96% of respondents indicated the use of invasive coronary angiography for surveillance at their institution. Intracoronary imaging was used less commonly. We see here in just approximately half of all centers. And this is usually because of clinical indication or according to protocols for their particular program site. Non-invasive imaging on the lower panel is also commonly performed. So in these results, about 75% of centers would use some form of non-invasive surveillance, but the exact modality that is used is quite variable. This is the data that is available for this practice. Let's start with invasive testing. So invasive coronary angiography is the current recommended standard for defining CAV, and based on the severity of stenosis, the number of vessels affected, and whether or not there is graft dysfunction, the disease is graded 0, 1, 2, 3, corresponding to no significant, mild, moderate, or severe disease. And these are recommendations from 2010 from the ISHLT, the International Society of Heart, Lung, and Transplantation. And this was put out because angiography is widely available, it's associated with low risk, and because at that time there was some prognostic information linked to angiographic data, specifically this multi-center study that showed that if you had severe angiographic CAV3, there was a 50% likelihood that you would progress to death or need for retransplant within 5 years of follow-up. And this grading or classification system has since been externally validated. This is one of the larger studies that included just over 500 patients who had annual angiography until up to 20 years post-transplant. And we can see that patients with angiographic disease, and particularly anything that's greater than moderate CAV 2 or 3 disease, had significantly reduced survival-free from retransplantation. Of intracoronary imaging. So intracoronary imaging is used to detect CAV early, and it is able to achieve this because of its ability to visualize the arterial wall and detect the early intimal hyperplasia that is otherwise not visible on angiography. And these are three of several studies that have shown that in the absence of angiographic evident disease, if you had evidence of intimal thickening, either early post-transplant, so the presence of donor disease, or if there is IVUS-only evident progression of disease, so no angiographic disease, all the way up to 5 years post-transplant, that this was associated with adverse clinical events. OCT is the newer form of intracoronary imaging that is being applied, and it's ideal for the assessment of CAV due to a high 10 micrometer spatial resolution that is 10-fold higher than IVUS. And you see here that on OCT, it's very easy to discern the intima, media, and adventitia layers of the coronary wall, and that by tracing these layers across cross sections along the vessel, it's possible to derive volumetric assessment of the intima, media, and adventitia with significant accuracy. Also on OCT, we're able to characterize plaque, and various components or plaque morphologies have been found to be associated with clinical outcomes, specifically angiographic progression of disease. Invasive testing, I did want to mention invasive coronary hemodynamics. So it is possible to use dual pressure and thermistor sensitive wires and float these down the coronary vessels to measure FFR, or fractional flow reserve, that's specific for the epicardial vasculature, index of microcirculatory resistance, or IMR, that's specific for the microvasculature, or to measure coronary flow reserve, CFR, that measures blood flow across both compartments. And abnormal coronary physiology measured in this manner has also been found to be associated with post-transplant clinical outcomes. And talk about PET. As I showed you in the survey, more than the majority of programs will use some form of non-invasive surveillance for imaging surveillance for CAV, but vary in their selection of imaging modality. And we have been using PET, and PET has several advantages, but probably the most important is its ability to quantify myocardial blood flow and therefore detect homogeneous reductions in flow, which you might theoretically expect to see in classic CAV, where there's diffuse disease or disease involving the microvasculature. And there's also increasing amount of data showing the prognostic utility of myocardial blood flow quantification by PET in the heart transplant patients. What remains uncertain is the optimal PET parameters or measures and their respective thresholds that should be used to define CAV at various times post-transplant, as well as to prognosticate this patient population. And this formed the rationale for our initial PET-CAV study to look at ideal PET parameters and their cutoffs for detecting CAV and subsequent validation of the results. And so we assessed PET against the clinical reference standards of angiography, as well as IVUS, intravascular ultrasound, for CAV. And we found good discriminative ability of PET for CAV, as you see on these rock curves, with area under the curves of 0.77 to 0.81 in the derivation cohort, and similarly high area under the curves in the validation cohort. We identified optimal PET cutoffs, which was corrected myocardial flow reserve of less than 2.9, stress flow of less than 2.3, and a coronary vascular resistance of greater than 55. And when we combined these three parameters, we found that there was high sensitivity in the presence of one or more abnormal parameter for detecting CAV, as defined by intimal thickening on IVUS, so very mild early CAV, and high 88 to 90% specificity when all three parameters were present. And that we could use this data to help us determine whether or not we needed to proceed with invasive testing, or whether we could continue with non-invasive monitoring with PET. This group was the first to report on the prognostic value of PET flow in the heart transplant population. This was a retrospective study including 140 patients that were at a median of 8 years post-transplant. And in this study, patients with a myocardial flow reserve of 1.75 or less had a fourfold increase in adverse cardiovascular events. More recently, we looked at the longitudinal assessment of PET in a slightly earlier post-transplant population, less than 6 years post-transplant. In this 121 patient cohort, 22% had experienced the primary composite outcome. And we found that reduced stress flow on the initial PET, less than 2.1, and persistently elevated coronary vascular resistance, more than 76, was associated with poorer clinical outcomes or lower freedom from adverse events. And there have been many other not many, but several other studies reporting on the prognostic information that PET is able to provide. I'm not going to go through these in detail, but I did want to show you some of the parameters that have been found to be useful. So this is one of the first studies by Bravo and colleagues that showed that a combination of an abnormal perfusion defect on PET with reduced stress flow less than 1.7 and reduced left ventricular ejection fraction of 45% or less was associated with adverse outcomes post-transplant. This is another study by Koneman that showed that an MFR of less than 2 predicted adverse clinical events. And this is one of the larger studies that actually showed that PET flow either reduced at the initial study or reduced on 2 serial scans predicted all-cause mortality. So this, the previous studies had some patients, it had some mortality outcomes, but this is one of the largest studies to report on this. We recently completed the ECAV study that integrated many of these tools that I've just discussed. This was to characterize anatomic physiologic alterations in the coronary vasculature in the first year of heart transplantation in order to determine coronary anatomic physiologic phenotypes and predictors of early CAV development. And this study was conducted at 2 institutions, and patients underwent multi-modality coronary evaluation at 3 months baseline, as well as 12 months follow-up post-transplant. I'm going to show you the data just from the invasive coronary studies that included angiography, intravascular ultrasound or IVUS, OCT, as well as invasive flow measurements. For the OCT, this was analyzed manually offline by cross-sectional analysis in 1 millimeter segments along the length of the vessel. This was single vessel examination, so we only looked at the left anterior descending artery. And we derived the intimal vessel and lumen volume, and also something called percent intimal volume, or PIV, which is the proportion of intima to the actual vessel. And the plaque was also characterized according to either normal, fibrotic, fibroatheroma, or calcific. And we also noted the presence of bright spots, which indicate macrophage infiltration. Coronary flow, as I showed you before, in terms of the technique, and we defined abnormal flow as an FFR of 0.8 or less, an elevated IMR of 25 or more, and reduced CFR of 2 or less. And we measured several CAV outcomes, which I'll describe as they come up in the results. But importantly, we define CAV progression as the change in percent interval volume between the baseline and follow-up studies. And so this is a table summarizing the patient demographics, and we see that this patient cohort is quite representative of the contemporary current patient cohort. 60% were male, the mean age was 51. Sorry, I'm just having some trouble because this thing is obstructing my view of the screen. That the predominant indications for transplant were ischemic or dilated cardiomyopathy, and that the mean age for the donor was 34. We included 5 donors who were hepatitis C positive. And 30% of patients were bridged to transplant with a durable LVAD. And 25% approximately of patients required treatment for cellular rejection in the first year, and 16% required treatment for CMV infection. And then on universal statin therapy, there was a significant reduction in cholesterol from 4.8 to 3.9. And in terms of the immunotherapy, both study centers were induction centers. So all patients had induction immunotherapy with ATG or antithymocyte globulin being used most commonly. And then patients were initiated on standard triple immunotherapy that included a calcineurin inhibitor, mycophenolic acid, and prednisone. Only a very small number of patients were started on sirolimus within the first year of transplant. So on OCT examination, we found significant progression of plaque in the first year, as seen by the increase in median PIV or percent intimal volume, as well as intimal volume, with negative vascular remodeling with reduction in vessel size and culminating in a reduction in the lumen. And then on characterization of the plaque on OCT, the predominant plaque was fibrotic. This was both at baseline and at follow-up. And there were no significant changes in FFR, IMR, or CFR. But note that abnormal physiology was common and seen in 41% of patients at baseline and 45% of patients at follow-up, and that this included 1 in 5 patients with an elevated IMR of 25, representing microvascular dysfunction. Looking at the incidence of CAV, firstly, the red lines represent patients with donor-transmitted atherosclerosis as defined by maximal intimal thickness, or MIT, on IVUS of 0.5 millimeters or greater at initial examination, and this was observed in 50% of patients. De novo CAV represented in blue. So these are patients who on follow-up had an MIT of 0.5 millimeters or greater, but did not have donor-transmitted atherosclerosis at baseline. And that rapidly progressive CAV, which is defined as an increase in 0.5 millimeters in MIT between the two studies, was seen in 11 or 13% of patients. There were no differences in whether or not these patients had initial donor-transmitted atherosclerosis or developed de novo CAV. And when we looked at the coronary changes according to whether or not patients had donor-transmitted atherosclerosis in the light gray and de novo CAV in the dark gray, we see that there were significant increases in intimal disease as you would expect compared to normal patients. And then we attempted to look at the sort of combination of abnormal anatomy and physiology. So abnormal anatomy was defined by either the presence of a fibrotic plaque or intimal thickening using a 0.5 millimeter cutoff. And abnormal physiology was defined as microvascular dysfunction or IMR greater than 25. And these are pie charts showing the prevalence of these phenotypes at 3 months and then at 12 months post-transplant. The red represents patients who have both normal coronary anatomy and physiology. And you can see that abnormal is more common than normal. And then when we looked at the coronary vessel changes according to these phenotypes, you see that there is a trend towards increased CAV progression in patients with either abnormal anatomy or physiology in the blue, and then and higher in patients with both abnormal anatomy and physiology in the yellow compared to red, which were patients with both normal anatomy and physiology. Predictors at baseline for CAV progression in the first year on univariable analysis, donor age, donor transmitted atherosclerosis, and recipient male sex were associated with early CAV progression. And then on multivariable analysis, we selected the OCT-MIT fibrotic plaque and IMR as anatomic physiologic variables that we wanted to look at specifically. And then we adjusted the model according to baseline demographic variables at a p-value of less than 0.1 on the univariable analysis I showed you on the previous slides. And then removing collinear variables, OCT-MIT donor age and donor transmitted atherosclerosis yielded a model in which a fibrotic plaque on baseline assessment or elevated index of microcirculatory resistance, IMR, so microvascular dysfunction, and recipient male sex were independent predictors of CAV progression in the first year of transplant. To summarize those findings, because I just threw a whole bunch of numbers at you very quickly, we found in this analysis or study that there was significant progression of coronary disease in the first year post-transplant, and that this was predominantly due to increase in intimal disease. So that's that PIV number that I alluded to at the start. So patients went from 10% to 17%. So that's a 7% increase in the first year, which is very high. There was also some negative vascular remodeling, so reduction in the actual vessel size, and that this resulted in a reduction in the lumen, and that the predominant plaque morphology is a fibrotic plaque, and that early microvascular dysfunction is also relatively common, affecting 1 in 5 patients. And that early microvascular function measured by IMR and fibrotic plaque are independently associated with 1 year post-transplant CAV progression. I leave ECAV, I just wanted to also share some of the preliminary data from some of the smaller sub-studies. Firstly, biomarkers. So in earlier work, we utilized an assay called SomaScan. That's a biomarker discovery tool to look at a very selected transplant population who had severe as well as mild CAV as well as no disease. And we identified 14 candidate proteins that were involved with apoptosis and injury and platelet activation as well as inflammation that appeared to be potential markers for CAV. And so we selected 3 of these markers and used ELISAs to look at them in the ECAV cohort. We found that, and we looked at ICAM2, ERB3, and tissue factor, and they were negatively correlated with the PIV, which, if you recall, is the epicardial CAV measure that we used in the study. And then these are the ROC curves for the respective biomarkers at 1 year post-transplant, where CAV was defined as a maximal intimal thickness of 0.5 millimeters or more on IVUS. And you see some promising findings for ICAM and ERB. And so work is ongoing to look at additional biomarkers and whether or not the combination of biomarkers might be useful for detection of CAV early post-transplant. Patients in ECAV also underwent PET. If you remember, I showed you that there was no change in invasively measured coronary flow, but that was only measured in one vessel, whereas PET measures blood flow across the entire heart. And on PET, we did see significant improvements in flow in the first year with increased stress myocardial flow as well as myocardial flow reserve. CVR, which is a measure of microvascular function, was unchanged. At 1 year post-transplant, these PET parameters were associated with IVUS indices of CAV. And as expected, stress flow was positively correlated with PIV, whilst CVR and, it negatively correlated or inversely correlated, whilst CVR and PIV were positively correlated. So this suggests the potential for using PET for detecting CAV early post-transplant. I did want to also touch on endomyocardial biopsies, which was something that the ECAV cohort also underwent. This is a slide that I've taken from a patient that I biopsied because he had a drop in his graft function, which was later found to be due to CAV. And you can see that on this biopsy, I nicked a couple of intramyocardial blood vessels, and that these vessels are thickened, the walls are thickened with the typical findings of CAV that I showed you on one of the very first slides. And this is his angiogram. On the left, you see that he's obstructed his LAD terminal circuit as well as his first obtuse marginal. And on the right coronary artery, he's blocked off his PIV. So the endomyocardial biopsies present an opportunity for examination of the microvasculature. And we perform biopsies, particularly in the early post-transplant period, routinely looking for rejection, but we don't really use it to screen for CAV. This is some earlier work by Hyman that graded the extent of microvascular disease, or what they term stenotic microvasculopathy, on endomyocardial biopsies. And what they found was that patients who had evidence of what they term stenotic microvasculopathy, where you've got thickening of the walls of the smaller vessels, had reduced survival. And this was patients who had microvascular disease, but no evidence of angiographic disease. And so this raises the thought that perhaps you can have microvascular and epicardial disease occurring separately. And we looked at this in a smaller patient cohort and found the same, that there was discordant microvascular and epicardial disease. So in this particular small group of 52 patients, 25% had evidence of microvasculopathy. And this figure in the patients with microvasculopathy are represented in the white bars, according to whether or not they had epicardial disease by angiography or on IVUS. And if you sort of fiddle around with the results, you'll find that 52% to 62% had discordant microvascular and epicardial disease. And this translates to missed microvascular disease if we only examine the epicardial vessels by angiography in 19% and on IVUS in 8% of patients. And in the ECAV cohort, the stenotic microvasculopathy was actually very rare, but as I showed you in an earlier slide, there was quite a lot of epicardial disease. So again, showing this discordance between epicardial and microvascular disease. And then if you looked at epicardial anatomic disease and microvascular dysfunction, again, we see that there is discordance. So at baseline in the ECAV cohort, 46% of patients and 57% of patients at follow-up had discordant epicardial microvascular disease. So this was either that you had microvascular dysfunction, your IMR was elevated, but you had no epicardial disease, or vice versa. Mean, do we have enough data here to put it all together and know what to do with our patients in terms of determining who we should be doing invasive testing on, or who we can just continue to screen for CAV using non-invasive testing, or do we have to do more work? So going back to this survey and now looking at what clinicians think with regards to surveillance of CAV, and these questions are directed at determining whether there is equipoise with respect to invasive versus non-invasive testing, and also for non-invasive imaging, whether there is a preferred modality that we should all be adopting. And without going into the questions and responses in detail, there was indeed equipoise, and that most physicians were comfortable using a non-invasive approach, and that there wasn't a specific preferred modality that they would like to use. And this is and this brings us to the Mariner trial, which is the our proposed study that has the primary objective of assessing whether a non-invasive PET-based surveillance strategy for CAV is non-inferior compared to invasive coronary angiography with respect to a clinical composite outcome of death, retransplant, graft dysfunction, and angiographic CAV associated with myocardial infarct or heart failure, and with the secondary objectives of evaluating whether this strategy, PET-based, would safely reduce the frequency of invasive angiography, improve patient quality of life, as well as reduce healthcare resource use. And this is the study trial design, which I won't go into as it's a work in progress and a subject of a recent grant application. So to summarize our current, or what I think is our current knowledge on CAV evaluation, I think the first important consideration is that both the macro and microvascular coronary compartments are involved, and that there are resulting anatomic and physiologic alterations in CAV, and that there is discordance of macro and microvascular disease as well as anatomic and physiologic changes, and that these have to be kept in mind when we are determining what tools to assess patients with for CAV, as well as in interpreting the results. and that invasive angiography is the current diagnostic gold standard, but it really does miss a lot of CAV disease, particularly diffuse or sort of microvascular disease and early disease, and that intracoronary imaging is definitely superior for early disease detection because we can quantitate and characterize plaque, and that intracoronary flow assessment provides additional functional evaluation and, importantly, evaluation of the microvasculature, which is otherwise difficult to do. And perhaps we need a new classification for particularly early diagnosis that would combine both intracoronary imaging and flow. And that non-invasive imaging to identify patients, I think the role of non-invasive imaging is to identify patients that require invasive testing and also for prognostication post-transplant. And that at present, the evidence for non-invasive testing for detecting early CAV is still quite limited, and that the tools, we didn't really talk about this, but the commonly used modalities for CAV surveillance, non-invasive modalities, dobutamine stress echo and SPECT, are really not very good in terms of their diagnostic performance, and that PET flow quantification definitely appears very promising, but we need consensus and more work to determine what the optimal diagnostic and prognostic measures and thresholds would be, particularly with regards to different times post-transplant. And all this to say, we do need more research and work. So I'll end by just thanking the many and essential collaborators that bring the needed expertise from interventional cardiology, imaging, pathology, and research methods that make this work possible. And thanks also to the research staff, and to acknowledge our funding sources. Thanks.
For the live audience, please raise your hand or come on up to the podium, and we can. You have to pose your question over the microphone. And for the virtual audience, please use the Q&A feature if you could. So I think we have it up there on the screen there. So feel free to pose the questions. I'll ask a question.
Good, because I don't think anyone else has one.
Well, I'll give it some time, okay? So I was actually surprised that, given it seems to be more of a recipient response, right? Then why did the extremes of age not come out in your analysis there?
You know, it's a small, this is ECAV you're referring to, that it's a small population. It's only 82 patients that we looked at. We don't, the sort of spread of ages that we transplant is not as wide as you may think. And so I think just trying to examine that in the required detail is probably difficult to do. Mm-hmm. But you're absolutely right. Recipient age is a documented risk factor for CAV development in other series, as were some of the other demographics that we failed to identify in this particular cohort.
Okay. And you did find male sex was a predictor too, right? Mm-hmm. So why aren't you just putting them on higher degrees of immunosuppression right off the bat? And
yeah, again, I think you know, that would be sort of the next step in terms of translating some of our findings to clinical practice. So the same could be said of patients who identify with microvascular dysfunction or fibrotic plaque. You know, what would we should we be giving them, treating them with an mTOR inhibitor immediately post-transplant to see if they have less CAV progression? But they are definitely a target population, but we don't have the data to say that that practice is going to influence outcomes in a positive manner. But absolutely, that patient population, males, microvascular dysfunction, fibrotic plaque, would be a potential target for both looking at their coronaries earlier as well as implementing mTOR inhibitors.
Yeah, and it looks like it's sort of progressive over time too, right? So it's not all happening right off the bat in the first year, right? It's from your earlier talk, it looks like it's progressing over the first 5 or 6 years at least, right?
Yeah, so I mean, I think that the pathogenesis for CAV is complex, and that factors that are relevant early post-transplant are different to later post-transplant. So to put it sort of to oversimplify it, it seems to be sort of more immune factors are important early post-transplant in delaying disease progression, and hence probably why we do observe that if you use an mTOR inhibitor early post-transplant, you can make a difference, but then later post-transplant, and by late, there's disagreement as to what that actually means, is that, beyond 3 years, beyond 5 years, beyond 10 years, we know that these medications have less of an impact, and we then we do this all the way right from the bat. But vascular risk factor modification perhaps it becomes more relevant later. A lot of our patients develop diabetes either as a direct side effect of the medication or sort of secondary. And that may be important for later development of CAV, but not early.
Good. So Ross Davies has a question there. Sharon, nice work. Are there different biomarkers for PET, MBF, and CAV compared to with antibodies and cellular markers of rejection?
Hi, Ross. Long time no speak or see. Nice to see you online. I think that we don't know. So there are no established biomarkers for CAV is the simple answer to that. As you know, Ross, many centers are now using other biomarkers for rejection surveillance. And so, for example, AlloMap with the gene profiling donor-free DNA, cell-free donor DNA, and then more recently something called CHIP. That these markers, that these biomarkers for rejection may also have some important applications with regards to CAV. I think it's very sort of difficult to tease out because, as you also know, with the immune mechanism and involved in development of CAV, as well as rejection as a risk factor for CAV, there is a little bit of overlap. So, are we, whenever there's a promising biomarker, what is it that we're identifying? Are we sort of just identifying patients that have rejection or at risk of rejection, and that leads to CAV, or are we, are we looking specifically at what's occurring at the coronary vessels? Okay.
Yep.
Thanks, Daryl. Thanks, everyone. There's Anyong. How do you reconcile the more recently findings of CAV